So we are going to talk about an item which, as an MPN patient, I think we don't really like to talk about it. It's the only real solution which we have for our MPN, which would be a transplant. And I've been trying to bring here a few specialists together. And what we will do is we will start with some people who went through a transplantation, who had the experience. I think Dolph is missing. He will also join us here. And then we have Dr. Manuel from Portugal. He is a specialist in transplantation. Yeah. Sit down here. And the rest will be patients who has been here. Then we have a doctor here. She is from the Fundación Josep Carreras. Josep Carreras, she is handling the donation lists. We get more information about this. Yeah, we would like to start with people who has been transplanted, and we put first a video. Okay, so we have two. Okay, so it's a Zoom connection. I have to warn it's in Spanish, so you will have to put your hats on. And let's listen to them what they're telling us, yeah?
Actually, we have Montse, she's from Spain, and Flor, she's from Latam. Hi, Flor. Just one moment, we're going to put both on you. Just one moment, we're going to put both on you.
Good morning, Flor. Montse, we can see you.
Okay, good morning.
We're gonna give you the floor. Thanks a lot for coming. I know there it's 4 a.m. Thanks for the effort. And we'd like you to explain us a little bit your process back in your country. How are you dealing with it? How was the transplant process and how are you feeling right now? Thank you.
Yes, well, thank you very much. It's a pleasure to be with you. I don't mind about the hour. Thank you very much. I think it's truly awesome that the events like this one, in which people who are going through this or people who have received a transplant already, we can tell our story. I was diagnosed in 2020 of myelofibrosis, primary myelofibrosis. I live in the northern state, a Mexican state called Chihuahua, and of course, with the diagnosis, I was really shocked. It changed my life. I was very happy, and then a diagnosis can really change your life. It's a rare disease, which makes it very difficult to have many voices talking about it. I had the fortune to receive treatment in my own state and also to speak with other doctors from all around Mexico, and there was no doubt that it was myelofibrosis. It's been 4 years that I took um, ruxolitinib. I lost 14 kilograms. I had no energy. When I started taking ruxolitinib, things started to improve. But then for 3 years, there was a lot of tiredness, continuous infections, and with ruxolitinib, uh, it was useful for only 3 years because then it stopped working and things got quite difficult. My spleen was already at 30 centimeters, a lot of pain, a very difficult moment altogether. Uh, and then they took the spleen out, and um, we were looking for a donor through an association in Mexico because I had nobody in my family, so we found somebody in the US. And then we started with the bureaucracy because the organism which um, organizes everything, it doesn't allow the cells to come here into Mexico. And so, yeah, after surgery, I was waiting for 7 months to get the bone marrow in the country, and then in February 2024, I finally received the transplant. I arrived with a low surviving chance because I was very weak, and it took a long time to get the bone marrow into Mexico. And then the process was very hard. I was in the hospital for a month, but with no difficulties whatsoever. And then after the hospital, I was for 2 months just at home taking care of hygiene. And then I could go back to my work after 3 months of receiving the transplant. I have not had any complications afterwards. My blood tests are going great, just a bit of lymphocytosis. Then everything was great because, after the diagnosis, nothing is easy. But here I was feeling I was fighting for a chance. It changed my life. And what I think that these sicknesses have, it's that they are hard, um, without any perspective, and the transplant actually gave me a chance to fight. And I had the luck of not having GVHD or any complications. Well, everything that I was told could go wrong actually didn't happen. So I'm very happy I got my life back, and now I see it in a whole different way. Once you go through these little things, you still see them like little things. And the transplant, despite all the crises, I think it's the key. This has been my experience.
Thanks a lot, Flor. Thanks for sharing with us your story. We're gonna leave the floor
Hi,
to
good
Monse.
morning.
Good morning.
Well, my experience is much briefer. I was diagnosed in 2024, and the 16th of July of 2025 I got the infusion. So it was everything very quickly. I was diagnosed with myelofibrosis, but I didn't qualify because they couldn't make sure if it was primary, secondary, or whatsoever. So they went to the transplant because I was strong and I had no symptoms at all. What I felt was that I was very tired, but I went before going to the hospital and I was working, so I don't know. I was medicated with Hydria and all of that, but I think the best thing was the transplant. I feel amazing, actually. So I always say that for me it was a big solution and I feel amazing. I want to go to work, but they don't let me. I don't know why. And I don't know what to tell you, but. And I was a month.
I do have a question, Monse. Monse, could you explain us how was the process of donating, if it was through a
No,
family
at first we tried
relative
to
or
do it
not?
with a family member. It was my son, the one who was going to make he was gonna be the donor, but because he had spasticity, it was complicated. It was an international donor, and I think that two came that were 100%. And what the transplant
Perfect.
was, I remember it as something beautiful. I have a very beautiful remembering. And I had mucositis during the month that I was there. it was horrible. Yeah, that was horrible. But afterwards, little by little, when I went out a month and so at first, I had a lot of pain. My arms were asleep and I didn't understand things, but I was getting over it with time. And I have corticoids still, but I feel amazing.
You're at home now, right?
Monse, are you already home? Trying to
Yes,
a
right
normal
now I'm
life?
in Zaragoza. I went the 4th to Barcelona and I have to go the 5th again. And we are taking it to Zaragoza. That was our first where I was going to have the transplant if it would be with my son. And the doctor said that being with him, we could do it. But I'm already at home.
That's amazing.
Thank you
Thank
so
you
much.
and good luck. I hope everything goes well for you.
Alright, to both Flora and Monse, we're gonna talk right now with two professionals. We have Dr. Alejandra from Foundation Carreras of REDMO, and then we have another doctor from Portugal. If you have any question that you want to ask, we'll
Thank
give you
you.
the floor later.
Thank you. So we had two testimonials here.
Doesn't work? I would like to present to Peter. We are, besides having the same first name, we are close friends for many years. We have been battling on the MPN front in different places. And he lives in Italy, but coming from Germany. And we have been very, very good friends. We are very good friends. And he went through the whole process also, and I would like if you could just give a little bit your story.
So I tell me my story coming from Italy, from Rome. Originally I coming from North Italy in South Tyrol in the border from Austria. But now I living 45 years in Rome. So my story began 2008. It's all okay. I have many headaches 2-3 years before I discover my illness. I don't know. I have only the drug for headaches. I don't know what I have it. So one day coming home after work, and in the morning I wake up and have my hand, the right hand is very so, and right there and here also. I don't know what I have it now. So I go to the hospital with my motorcycle also, and say all is blocked and the blood not make circulation in my arm. So I go in the hospital and the first things making heparin now for the blood is more liquid now. And after discover after 3-4 days I make bone marrow what is the name?
Extract.
Yes.
Extract.
No, extract for yes. So I discover polycythemia vera, JAK2 positive, and all these things begin there. So this is now many years ago. So I begin with bloodless. The first time, 3 times in a week. I have my hemoglobin is very high. I have a 22, so my blood is very deep, like oil. No? So with many bloodless, many after 2 in 1 week, after 2 in 1 in 1 week, I make this for every year. So the second year after, I tried the first treatment with the PEG intern for 8 months, and it's not working. I make the bloodless every month and not have effect. So I stop it. I continue with idusurea. This is what is the name in idusurea? Is yes, you understand. And with this is working. I have one blood loss in a month and the chemotherapy also in the same time. I continue for many years, or 8 years, 9 years. So after try other things with Jakavi ruxolitinib, 8 months also. I had to stop it. I have. You see what I have it. I stop it. It's very. I have inflammation of the joints, and it can make nothing. So I have pain inside. So I stop it. Also this one, and the same year in month of November, I have fever, high fever, 37, 38, 38.5, all the day, all the night. So in my body things is changing, no? So I use it only paracetamol for make this not so too high. And after I make other bone marrow biopsy for looking what I have it. So the next step, I have secondary myelofibrosis from polycythemia vera. So I have myelofibrosis coming from polycythemia vera. And after a new analysis, I find a precursor from leukemia inside. So my hematologist say, now important stage, donor. I make the transplantation. You don't have money, many time. So start the research in the international register from donor in all the world. And I have a chance after 2 weeks to find a young man in Germany with 22 years, is 100% compatible with me. So make all the things for extract the bone marrow in Germany from the blood, from the not from the marrow directly. The blood was you have the information from them. And so come this thing with 250 grams is like a pink color. Rome with the airplane, and after make this inside in 8 March 21, and in hospital in Rome in Umberto Primo, this is one from the 2 biggest hospitals from Rome, and stay there more than 1 month to me, and it's working very good. Not have graft, not have reject. All the time after 1 year and 2 months, I stop at cyclosporina. This is the things but not have it reject. No? So everything go good. You see me here now. My blood analysis now is like before I have my illness. So it's all perfect now. The white, the red, everything is inside. So I have 2 births in the year. The birthday, the first one, and the second birthday, the 8th Mass. This is the day from the woman, no? 8th Mass in the world. So I'm very happy to stay here. I see Peter many years before I have this problem. No? I have PV all too. Now no.
Now we're separated.
Yes, separated now. So I have also in Italy a big organization for the patient, IPAM. I have more than 2,000 people, and from all regions, from North Italy to South Italy, Sicily. I make the meetings in all the city around in the year. So so this other story. 2008, have this illness, not exist in Italy. Association, nothing. No. So I looking in internet, and I see I can live only 6 months with what I have it. No. So I think so only 6 months is not much. No. So all people from children I have. I want nice car. No. I have a dream. So I want every time I buy a Porsche. So now I buy the car Porsche, so I can live only 6 months. I use it, no? So I sailed the Porsche last year, so I not died. and this is a nice thing, so it's positive. So now I help other people. Is in a year from the transplantation, so I have now experience now, all experience from the beginning, just now. And I'm very happy help other people. They make a transplantation immediately or is programmed, and so this is now my goal. Before it's different. Now I want the people or the young people survivor, and now the treatment is very more than before. 2009, 2008, find the JAK2 2 years ago, before 2005. So I have nothing, only the old drugs like idursulfase. So now I see you have many inhibitor and coming out other inhibitor end from this year. So the chance for living better is very high. This I think for you is a good thing, no? Thank you very much coming here. And it's okay.
So, Dolph, another survivor.
Alive and kicking. All right, let's start. Some parts will be hard to hear. So I will start with like a fairy tale. He lived happily ever after. So remember that when I tell my story. I was 54 years old and doing sports. I had a family, had a tough job, and suddenly I became tired. Started coughing, and I was playing soccer, and the guy said, "You're getting old, you're getting old." I thought, well, that's not good, the coughing, and I went to my general physician, and he took a blood count, and he said, "Well, this is no good." I think he made a phone call on a Friday afternoon. He said, "I think you've got acute leukemia." I said, "Thanks and have a nice weekend," because I couldn't do anything anymore. He said, "I make an appointment next week at a hematologist." It took them 4 weeks in a small hospital in Holland. I live in Holland, in the middle. And they couldn't find it. It was the hospital I was an IT manager in, so I knew all the doctors. And I said, "I helped you from your IT problems, now you help me from this problem." But they couldn't find it. They sent me to a huge hospital in the middle of an academic hospital, and it took them 2 weeks, and I got the diagnosis, myelofibrosis, and it was already very far, high stage, and he predicted me 1 year to live if we didn't do anything. I said, well, I want to continue living, so let's do something and do a stem cell transplant. And we did. It was in October. I got a diagnosis, and we planned the stem cell transplant for February the next year. It was all worth the risk, because life with my myelofibrosis was already my symptoms were so hard, it was impossible to continue that for a long time. Unfortunately, 1 day before I was should be admitted in the hospital, that night I got a high fever, a lot of headaches. I really didn't know what I felt. Immediately, so sick. I said to my wife, "Well, this is no good." We made a phone call to the hospital, went to the hospital, and after 24 hours searching, they found I got a Streptococcus A bacteria that can be deadly, and it was due to neutropenia. I got low, my white blood counts were, of course my blood counts were very bad, and my white blood counts were also bad, and yeah, I was unlucky. I was lucky that I'm a positive man, so I was lucky it wasn't 2 days later, because then I was on the chemo and I would die. So this helped. We postponed the stem cell transplant. 2 years I recovered. 2 years later, I was a well-informed patient. I thought it was interesting. I was at a doctor that was one of the best MPN doctors in Holland. And still, my MF morphed to AML. In 2 months, we saw the blast rising, and it was impossible to do a stem cell transplant before we treated the AML. So I would like to take this opportunity. If you do a CBC blood count, take care of your blasts. It's an important one. Don't be scary if it's below 5%. That's normal. But if you see an increase of blast, contact your doctor and ask about what's happening, because between 5 and 20% blast, it's morphing to AML, and above 20 it's AML, and you don't want to have that risk, because it lowers your survival probabilities. We beat the AML, and 1 month later I got a stem cell transplant from a guy from 27 years old. There were 3 donors, so I had a very common, my doctor said, oh yeah, you're really common man. We have found 3 donors, so they took the youngest one with the strongest cells. Unfortunately also, when you have stem cell transplant, you don't have any white blood counts, white cells. It takes 2-3 weeks until they come up. They can give you platelets, they can give you red cells, but white cells are the ones that do the match, and that must be the same one as you had before. And the white cells, they start growing. For myelofibrosis, it's a little bit tougher due to the fibrosis, but after 2 to 3 weeks, they start growing, and I was so happy to hear that the counts were from 0 to 0.1, and I said, well, it's working. They found a way, and they start working. But I got infection on my lungs, and they had to put me on ICU for a couple of weeks on respiration, and so it was a bad time. Talking about this, in Holland, we're talking about 11 years ago. Fortunately, they changed the way they put the stem cells to a person. I got all 3 lines in one bag. So red cells, white cells, and platelets, they all came in my body and started growing. But the white cells, they are trained to attack strange things. And if you're having if your blood is not good, you also don't have any power. You had chemo. You're not strong enough. And at the moment, the new way they put stem cells in your body is they first give you the platelets and your red blood cells. So your body starts to recover, and you get more energy. You're feeling better. Your body is more capable to fight. And when it's that way, then they give you the white cells that are the fighters, and so they fight against a better, a stronger body. At the moment, my blood counts are very well. They're all in line with healthy people. Cholesterol issue, yeah, can happen. That's the only one. And what I realized later, that what I did was, what I had gone through is very rare, and I'm glad to get this opportunity to show you that having MF or being through a stem cell transplant is not a death sentence. It's just, you are here, so you're already ahead of a lot of people that are not interested in anything of our illness. Being well educated can increase your quality of life, but it also can increase your survival chance. And I started in Holland. First, I started in Holland a Facebook group. I say we have a rare disease, but we're not alone. So that's why I connected 900 people on Facebook. Then together with John and Peter, we started MPN World to expand it from the Netherlands to Spain and then the rest of the world. Recently with Remco, we started, and John, we started MPN Journal, and Nick, who's not here. And I told them already when we had a coffee break, I'm so proud on the IAS. They do what I like. They connect to each other and learn from each other. And I said two things to them. My thoughts were, you are the next generation Peters, if I can tell them that, like that. And second, almost immediately after that, I remember the presentations we saw today or yesterday and the day before that. I said, well, I think there will be a time we will have it when you are not necessary anymore to connect to each other because problems are solved thanks to the researchers and the pharma. So that's my story. Thank you.
So now that we have heard the testimonies, let's go to details. I think if we talk about transplantation, the first thing is we find a donor. I think this is what you will talk about. And then Dr. Abecasis, he will explain what is a transplantation, how does it work, what are you doing, etc. He is, I would say, he's not an MPN specialist, he's more a CML specialist, but he's a president of a CML association in Portugal, but he has many MPN patients which have been saved by him, and I think he can give us a lot of information. So why don't you start and you explain us about the donor system. I hope it works.
Okay, good morning, everyone. My name is, from the beginning, please. Thank you. Okay, here. Good morning, everyone. My name is Alejandra Martínez, and I'm a hematologist. And today I will share with you the donor process selection from our register from REDMO. REDMO is the National Spanish Donor Register for bone marrow transplantation. In this agenda, I will guide you through how and when the donor search is started, how HLA typing is performed, how REDMO organized the search process, and finally, how donation is performed both from peripheral blood and also from bone marrow transplantation. So let's start. When the decision to start a transplant, many conditions have to be considered. First, from the disease. The disease has to be in remissions or really well controlled. Also, they have to be, the patient have to tolerate previous chemotherapies, and also they have to find a donor. The donor, to have a donor is really important in order to go to transplant. And from the patient, it's also important to have an ecosystem which is being in really good health with physiological age, and also to have a social support. This is the most important thing, to have a caregiver, a person that cares for them. After that, after the decision of transplant is taken, we have to search for a HLA typing, and also we have to choose for a donor. And the time to transplant is really important. Here from REDMO, we try to perform the search as soon as possible in the safely way. Okay. So first we have to perform a HLA typing. What is an HLA? It's a human leukocyte antigens. There are molecules that are expressed in your white blood cells, in the leukocytes, in the blood streams, and is like your immunological a reference. It's like having your first name, your security name, your birthday name. Is what gives you the identity of the of your immunity. And look at these expressions of antigens. These expressions of your antigens help you to battleize or for the infections. As HLA typing is critical to respond to the immunotherapy. If the donor is really compatible to you, as much compatible it is, the possibility to respond well to the transplant is better, and to avoid the risk of transplant rejections and complications such as graft versus host disease. So oh, sorry about that. So HLA typing is a technique which is made in cells that can be taken from your bloodstream or from your cheek. It's a DNA sample and doesn't require to be. It can be stored and analyzed later on after that. Okay, I give you all the information from the antigens, and each family have the possibility of have a sibling compatible. This possibility is around 25%, 1 of 4, because every person inherits half of the HLA type. So many patients don't have siblings and don't have the opportunity to have a donor compatibility. So that's why registers are really important to be able to find a donor for stem cells. So that's why REDMO was created, and was created around 1991 for a patient, and it was inspired for all the patients. And that was thank you to Josep Carreras. We create the foundation and also create the register to coordinate donor search for all patients, not only from Spain, but also for patients all around the world. And these registers also exist in other countries. In England, for example, it is Anthony Nolan. In Germany, CKRD. In France, FGM. And here in Spain, we have REDMO. We all cooperate in an international network, which is called World Marrow Donor Association, which give you the standard to proceed and analyze the matching donors and the serving for the search. So how REDMO works? REDMO works like an organization that coordinates all the centers that participate in transplant. We coordinate the transplant centers, we coordinate the collection centers, and also the recruitment center for donors. And we care for the donor safety and also for patients. We connect, we collect, and we recruit donors for patients to be able to have stem cells. And we follow the standards of the World Marrow Donor Association. So how the search process begins in REDMO? First, we need to have a request submission, and this request submission have to be performed for a transplant center or a unit that have the possibility to perform unrelated transplantations. With this request submission, we receive through our national registry, or when the patient resides from his national registry. And we electronically connect with the main international registry to process all sends and receive search process. Second, our coordinators have the objective to verify all the requirements to identify the potential donors, select the best available option, and confirm the possibilities, optimizing the times and the relation between the transplant and the search process. So we start the search, and in the world there are 43 millions of possible donors. So all people have a potential donor around the world. And we look for a match, which is an activation of the donor search. We coordinate and try to identify the most suitable candidate. Sample requests are performed to REDMO and request a confirmatory sample of this data set. So we send a request to the laboratory and confirm the samples, and the results are returned to REDMO. And the next step is the selection of the donor. And we come to coordinate the day 0, which is the day of transplant, and that's the most important day. It's the big day. It's the day when the patients have first a conditioning, which is a treatment to help to prepare the body, and they receive intensive chemotherapy in order to give a space to these stem cells to be transplanted, and also the donor begin the process to collect these stem cells, which is called mobilization, and that's 5 days before of the collection. So this coordination is really important to become the day 0 of the day of the transplant. So how is allogeneic stem transplantation in Spain? In Spain, it's growing every year. Here we have some data. In 1924, this have been increasing, and it's increasing especially because leukemias. It has been the treatment to cure leukemias in some group of patients. So that's why it's one of the main indications in not only here in Spain, but also around all the world. And also the age of the patient is increasing. Before, the transplantation was suitable for young patients, and now we are performing the transplantation for older patients. Even the median age here in Spain is around 50, but with the better the conditioning regimens and the new techniques to perform transplant, more patients with older age are able to enter to the transplantation, and the age here in Spain is around 70, but in some other, if the patient is in good condition, it can be considered older, 73, 74. But there's an exception, of course. So in order to respond to this increasing in the Spanish bone marrow register, is also increasing the donor recruitment, and we have 500,000 donors possible to donate for patients. Last year we recruit 30,000, which is a really good number, and that makes us the 5th biggest register in Europe and the 3rd one in the global position. And those are some data of our work. Last year we start a search for 1,000 we have 1,000 possible requests here in Spain. We found donors for patients. We found 2,000 donors possible for patients, and the median time for a result was 27 days. And that gives you the possibility to find a donor in 95% at 2 months. So in 2 months after the search is started, a patient will have a possible donor even in our database or in the global base. But we will have a result, we will have an answer, we have an option. Could be not be the best option. It could be not a 10 to 10, but could be a 9 to 10 or a 8 to 10. We have but at least we have a solution, a request and a possible answer to that request. So in the last 30 years, we have been helping 50,000 patients. We have give donors, or we coordinate 50,000 transplantation, not only for Spain, but also for the international. We have sent donors, and we have sent stem cells for 40,000 foreign patients. And and we have to take donors also that we will be able to help these patients, and we will be able to perform the match. So how the donate process is coordinated and how is the process? First, we donate stem cells, which are hematopoietic stem cells. These cells have two biological properties which are really important. First, they are cell renewal. They have the ability to divide and produce identical stem cells. Also, they have a multipotency, which is the capacity to differentiate into mature cell, which are blood cell, leukocytes, and platelets. Really important. And how to donate in Spain. This is also important to know and to see how young people can join the register and be able to be donors. First, you have to sign up, and you can sign up through our online page or to a driving campaign. You will provide some basic information about yourself, like age, health status, and contact details. You will receive like a swab, or also to perform the HLA taping from your cheek, or you can do it from a blood sample which is collected in that moment, and that will be sent to perform the tissue typing, to perform the HLA type that makes them to put this information in the global data set, in the donor register. If a patient matches the HLA, the register will contact you, and this is a possibility of 1 to 2,000 possibility, but probably for that patient is the only possibility. So that's really important to be able to donate. And then when the match is done before donation, that donor undergoes through a health assessment to ensure safety. They perform a medical history review. The doctor reviews that the donor past medical history is current without no important illness. We perform a physical examination, and we will also perform a blood test to confirm there is no any organ malfunction, and to rule out also infections. So how the process of donate is performed? The process of donation is performed by 2 ways: peripheral blood, which is the most common, and also the other one is through bone marrow donation, which is a 20% frequency. Peripheral blood stem donation needs to be mobilized, and thus be receiving an injection, which is called an injection of growth colony stimulator factor during 4 to 5 days. This medication helps to move the stem cells from bone marrow into peripheral blood, and then goes to a process which is called apheresis. It's a non-hospital procedure to collect stem cells from the blood. Blood is drawn, stem cells are separated and collected, and the remaining blood is returned to the donor. This procedure it takes few hours, and is well tolerated for the donor. So that's the medication is the granulocyte colony stimulating factor, which is applied before donation, and most donors tolerate it well. Some have some mild effects like bone or muscle aches, as you were having a cold. There are injections that are applied in the skin, and that's the way to have the donor apply it every day, 4 days before the mobilization. This is a mobilization scheme, which is this dose is adjusted for the weight of the donor. And that's the apheresis. The apheresis is the process where is connected to a machine, and the donor blood is collected, filtered, the stems are processed and separated from the blood, and then comes back, the rest of the blood comes back to the donor. And this is like as a photo where a donor is doing the process of apheresis, and you can see it's really is performed from peripheral blood. It's really sort of way of easy. And now I will explain how the donation is done by bone marrow. This is around 20% of the situation. It's a procedure requiring hospital admission, and is involved collecting the stem cell from the pelvic bone okay, directly from the bone marrow aspiration. The procedure is done under general anesthesia, is painless during the collections, and most donors recover quickly, and the body replaces the donated cells within a few weeks. So in summary, we have two ways of donate stem cells. One is the bone marrow donation, which is an inpatient procedure under general anesthesia, painless during the process, but it needs a hospital stay from the donor, usually 1 day. And the other one is a peripheral blood stem cell donation, which is the more frequently, is an outpatient procedure, is via apheresis, but requires a mobilization process before. All both processes are well tolerated and with mild effects. So with this, I was trying to resume the process of donation in Spain, and thanks to the donors, because if it wasn't for the transplant, we would not be able to perform.
Thank you. So we know how we select the blood, yeah. Now we come to my friend Dr. Manuel. He is doing really the work. I met him only a short time ago. We had a meeting in close to Lisbon. Can you hear me? Yeah? Yeah. And well, we talked a long time about MPNs, etc. It was the launching of Besremi in Portugal. And, you know, I started to know that he's an expert in transplantation. And as we wanted to talk today about this, I invited him to come here, and he accepted. So thank you very much for coming, for making this trip to us. And please go ahead.
Maybe I can use your
Sure. Oh, yeah.
Thank you very much, Peter. It's my pleasure to be here today. And I must say that I'm very impressed by this audience. I've never seen patients and doctors together in this gathering, and really that means something very special to me, and it's certainly a model that we want to follow in Portugal. Now, a lot of things have been said about mild MPNs today and on the previous days, and because for the sake of time, I will go through quickly some parts of my presentation. And doesn't seem to be working. I have to point there. Okay, okay. No? The down arrow. Okay, well, I tried that. It didn't work? Yeah, okay. Well, so talking about bone marrow transplantation in MPNs is not an easy subject, because it's the most difficult situation that we face in bone marrow transplantation. And you will understand why. I'm sure you probably know, or you guess the reasons why. When we talk about MPNs, I will talk mainly about. Okay. No. Okay. Okay. So, which MPNs conditions are really considered for bone marrow transplantation? And of those three that I did mention, it's primary or secondary myelofibrosis. These are the patients that that will benefit from a transplant. And the benefit of bone marrow transplantation for myelofibrosis is well established, but it raises questions that need to be answered when we're facing the patient with myelofibrosis. And I've listed here some of the questions. Why bone marrow transplantation? Which MPNs, which I have already answered that. How, who, when, and then very specific questions particular to the myelofibrosis. Why? Well, for the time being, allogeneic stem cell transplantation is the only curative treatment. We heard this morning from Professor Aifa that in the near future, probably things will change, hopefully. Although being a bone marrow transplanter, it would be very nice for me because I like to do good for the patients. And well, anyway, we know that bone marrow transplantation induces complete remission, and including molecular remission, and it can clear the marrow from the fibrotic changes that are in the basis of the disease. Now, these are the current recommendations from the European Bone Marrow Transplantation Group, the European Leukemia Net, so that bone marrow transplantation for myelofibrosis is recommended for patients less than 70 years old and whose expected survival is less than 5 years. This means that the selection of the patients that are proposed for transplant has to be very strict. We have to have a lot of communications with the hematologist that is following the patient in order to get the patients to the transplant at the right time. Otherwise, results will not be that good. Of course, the first thing is that we must make sure that the patient wants a transplant. Because when we talk about transplant, people think, well, probably it's not a very difficult thing. We heard this morning 4 very strong testimonials of patients who underwent the process. And I'm very pleased that results were so good at the end of the day. It's not always that, and we must think very carefully. And we have to be very open with the patients and explain them very carefully the risks and potential benefits of transplant. And that will take time. So my suggestion for my colleagues treating MPN patients is, well, think of the possibility of a transplant well ahead. When you have a new patient with myelofibrosis, send the patient to us so that we can talk to the patients. It doesn't mean that patient has to be transplanted, but the patient will have to know that this may be an option, and he will have plenty of time to think about it and discuss it with his doctor and even with his family. And this is really a very important point. And then what's the disease risk? Well, we know that myelofibrosis is a very heterogeneous disease. Patients can live for more than 15 years with minimal treatment, or they have very aggressive disease whose prognosis is less than 2 years, for instance. So in between, there's a lot of variation. So we have to think about disease-specific risk factors. We have to think about the transplant-specific risk factors. And of course, we have to think about the patient-specific risk factors. And all these 3 points need to be well balanced in order to offer the patient the best solution for treatment. Now, concerning the disease-specific risk factors, I guess that Professor Lau probably mentioned this or discussed this with you, so I'm not going to spend a lot of time with this. We usually use the DIPS score, which means Dynamic International Prognostic Score, to try to classify the risk of the disease for a particular patient. Because having such a widespread survival, we need to be more or less sure about the real prognosis of this patient. This is not it's not a absolute indication. We need to consider the patient that we're facing, because even patients, these are the points that are taken into consideration when we classify a patient with a DIPS score. And as you can see, the probability of survival is very different according to the risk score. Patients with a low risk score have an excellent prognosis. Patients with an intermediate risk score have an average estimated survival around 14 years. But patients who fall in the intermediate to or high risk score, the prognosis is not that good. So those are the patients that really need to be considered for transplantation. So that's what I mentioned here, really. If a patient falls either in the intermediate 2 or the high-risk DIP score, the patient should be referred for transplantation, should be very strongly considered for transplantation. Of course, we transplanters, we have our own score. We have, apart from the DIPs, we consider what we call the myelofibrosis transplant scoring system that helps us in predicting the risk of post-transplant complications that will help us in guiding the patient through the process. So we consider things like the patient age, also the mutation status, the platelet and white blood cell count, performance status, and of course, above all, the donor choice. Because we need to have a compatible donor, a fully compatible donor. The ideal one is a sibling donor, but as you've seen this morning, this is very unusual circumstances. All these 4 patients that gave their testimonial here this morning were transplanted with matched and related donors. And that's the situation that we face most of the time nowadays. When choosing, if the patient doesn't have a matched sibling donor, of course, we go for a search for an unrelated donor, as it was so well explained this morning. And again, using our MTSS score, we can stratify the patients again into 4 categories. Those who have a low risk of transplantation, intermediate, a high or a very high risk categories. And this will help us in selecting the particular patient. So patients that fall in the low or intermediate scores, they have excellent results. They have a probability of survival at 5 years ranging from something to 77% to 90%, which is really very good. Patients with high or very high scores don't do so well. It doesn't mean that they cannot be considered for transplant, but we know that results are not that good. And as you can see here, this is on your right-hand side, a validation score estimating the probability of survival after a bone marrow transplant. You see the top line, the blue one, is for patients in the low risk, which have very good survival, and so on. The lines keep dropping according to the risk, the MTSS score. So the ideal patient for transplant is the patient with a deep score of intermediate to or high risk, because those patients have estimated probability of survival less than 5 years. So we pick up these patients. And the patients who come for transplant ideally should have either a low or an intermediate myelofibrosis transplant scoring system risk. Patients that can combine these 2 scores really have very excellent results, very good results. And those are the patients that, of course, we like to transplant, because we know that we really can offer them a high probability of being cured of the disease. So, well, when it comes to selecting a donor, of course, the ideal donor would be a sibling, either a brother or sister that is HLA identical with the patient. When, as it happens in most of the times, a patient doesn't have a sibling donor, then we go for a matched and unrelated donor by doing a search in registries such as REDMO and other registries. And the third choice nowadays is considered to be an haploidentical donor. Haploidentical donor, it actually means that the patient and donor are only 50% compatible. And by using these three categories of donors, we can say that almost 100% of the patients will have an available donor. Because an haploidentical donor means that you can be transplanted with a sister or a brother that is only 50% compatible, or a son or a daughter, or even a parent. So it comes to having almost a donor for everyone. Of course, this is not the ideal situation. The ideal situation is the matched sibling, then the 10 out of 10 related donor, and then the haploidentical donor. And then donors that are matched from 9 out of 10, the results are not that good. So it's, if possible at all, we try to avoid this sort of donors. And of course, for any bone marrow transplantation, we have to consider the donor age and CMV status, and donor age and gender, CMV status, and the ABO blood group, among other things. Now, the next step would be to choose the best conditioning regimen for the transplant. What we call the conditioning regimen is actually the way patients are prepared to receive the transplant. We have to wipe out the patient's diseased bone marrow in order for the incoming cells to be able to establish the graft and work properly. So there are two ways of doing this. One way is using very high doses of chemo and sometimes radiotherapy, what we call a myeloablative conditioning regimen, which is pretty toxic. And taking into consideration that the average age of patients, myelofibrotic patients that come to transplant is well above 50, we try, whenever possible, to avoid the myeloablative conditioning regimen because they come with a high toxicity. So we go for a reduced intensity conditioning regimen, and we know that by using this, the toxicity is very much lower. The number of the possible complications is also very much lower than using a myeloablative conditioning regimen. Now, the next step would be choosing the source of stem cells. And as you heard this morning, the cells can be used either taken either from bone marrow or peripheral blood. We recommend the use of peripheral blood for all our patients, mainly for two reasons. One is the number of stem cells, and that has also been mentioned this morning, that you get in the peripheral blood is about 10 times higher than you get in the bone marrow. So we need lots of stem cells in order for the transplant to work, because we are working with a fibrotic marrow, and the engraftment, the working of the establishment of the graft is more difficult than in other transplants. So peripheral blood is certainly the best choice for the treatment. It also gives you another strong point, is that the recovery after the transplant is much faster. It's about 5 to 6 days faster when you use peripheral blood stem cells rather than bone marrow. And we don't want our patients to be in a plastic for a very long time. So the following point is to select the GVHD prophylaxis. And most of the protocols use what we call a drug we call calcineurin inhibitor, cyclosporine that has been mentioned here this morning as well, or tacrolimus, in combination with methotrexate. And this is a well-established GVHD prophylaxis, and it's known to work well for patients with myelofibrosis. Well, there, of course, in myelofibrosis, there are very important points to consider. As you know, patients usually come to transplant with a big spleen, so it's very important to reduce the spleen size. Not only because it makes the engraftment much easier, but it reduces the inflammatory milieu that is so common in myelofibrosis. Patients have constitutional symptoms, as you know, like sweating, fever, pruritus, and so on. And the easiest way to reduce this is by using one of the JAK inhibitors. The one that is usually used is ruxolitinib. There's very small experience using the two others that are currently available. So we usually recommend using JAK2 ruxolitinib before transplant, and at least for 3 months before transplant, before patients going to transplant. And by that, we can improve the constitutional symptoms and the general performance status of the patient. And this has a Okay, thank you. So this has a positive impact in the results of transplantation. So the current recommendation is to use a JAK2 inhibitor for at least 2 months prior to transplant. And in many centers, patients are kept on ruxolitinib during and after the transplant. And there are some centers where patients are kept on ruxolitinib for about a year post-transplant. Not only because that decreases the probability of a disease relapse, but it also is known to decrease the incidence of the graft-versus disease, which is a complication of allogeneic transplant, which can be very serious. Now, of course, there's always the risk of the disease relapsing after transplant. And so we have to follow this very carefully. We know that over 9% of myelofibrosis patients will have a driver mutation, and this driver mutation can be followed post-transplant, and we can pick up a relapse earlier after transplant and then act on that in order to bring the disease under control again. Something between 15 to 45% of patients will experience a relapse. Most of these relapses occur during the first 2 years after transplant. And we can rescue patients after relapse by giving donor lymphocyte infusions. Donor lymphocyte infusions have this very strong impact in controlling the disease. The donor immune system is really the most important thing to control the disease. And if we give donor lymphocytes when the patient relapses, a lot of patients will go back into complete remission again. Of course, the first step before this is stopping immunosuppression. So we have to stop. If the patient is taking cyclosporine or steroids, we have to stop the immunosuppression and then wait for about 4 to 8 weeks to see because sometimes just by stopping the immunosuppression, we can control the disease. So after about 4 to 8 weeks, if the disease is not controlled back in remission again, we go in with donor lymphocyte infusions. Of course, donor lymphocyte infusions come with an associated risk, and that is the risk of causing graft-versus disease, which can be a difficult complication to treat. But patients can be put back into complete remission again, and that's very important. Now, the good news is the long-term treatment for long-term survival outcome for patients who have a bone marrow transplantation and patients who are alive after 24 months after transplant. Those patients have an overall survival of 74% at 10 years after transplant, and a relapse rate which doesn't go away, but increases very, very slowly. This is really a very important point. So the key point messages I'd like to leave with you today is that BMT is so far, for the time being, the only curative treatment for myelofibrosis. Patient preference is very important. Patients have to be well instructed about the risks and benefits of bone marrow transplantation and be very actively involved in the decision. results for bone marrow transplantation in myelofibrosis have been improving over the last few years, particularly since the introduction of JAK2 inhibitors. And then the evaluation of the disease risk and early referral for a bone marrow transplant team is really very important. Thank you very much for your attention, and I'd like to...
Thank you very much, Manuel, for this presentation. Now, I'm standing here because I have a question, which I know he's a specialist, but I think it's not more than 5%, but only about 5% of MF patients might have to make a transplantation. Is that right?
Right. Yes, that is right. I mean, it's and reasons for that are various. I think the most important thing is to refer the patient in the appropriate time for transplant, assuming that the patient wants to be transplanted. That is really the main point. I mean, patients have to be well aware of the risks and benefits of transplant. And if being well informed they choose to go ahead with the transplant, then they have to be referred in the proper time. There's a window of where the results are really good, and we need to have a very strong collaboration with the treating hematologist, so that in between both we can make the right time for transplantation to go ahead. And things are, because the results in myelofibrosis were not that good, and I remember when I started doing transplants a long time ago, we would never consider a patient with myelofibrosis for transplantation. No way, because I remember trying. We started transplants in Lisbon back in 1987. So we tried a few patients, and I must say they all died. None of them did survive because they were referred for transplant very late. Huge spleens. We had no way of reducing. I mean, surgeons in our institution would not accept to do a splenectomy, and we know that splenectomy has a high risk of complications, and you need, in order to get the good results in splenectomy, you need to have a dedicated surgical team that knows how to deal with these patients, because they are really very difficult to go through. The other way is, of course, is doing splenic radiation. But that, again, is not an easy thing to do, because when you have a huge spleen, if you treat with radiation therapy, we are causing a very profound drop in blood counts, because a lot of the blood forming is done in the spleen. And so if by radiating spleen, patients is going to be a plastic, going to be, and then again, if patients go to transplant, I mean, they have radiation part of the bowel, and that's not a good thing, because we know that bowel radiation predisposes to development of graft-versus disease, not only because it damages the bowel, but also it changes what we call the microbiome, the intestinal flora, and that's something that we like to avoid. So by all these reasons, I think it's only very recently that the hematologists that treat myelofibrotic patients are considering going for transplant. And that's also associated, I think, with the introduction of JAK2 inhibitors that allow for a better control of the disease and allow for patients coming to transplant in a better shape. But I'd like to know what Dr. Lau thinks about that, because...
Yes, I'm sorry, I have. Yeah. It is a €1 million question. I think my sound is getting more like this. My sound is disappearing since last evening. I always say this is a €1 million question. what is the right time to send the patient to transplant. For younger patients, myelofibrosis, not the low risk or intermediate one, I always do a search from the beginning. I say a search doesn't mean an automatic transplant. The luck we have in our disease, it is not acute AML. So, but we have to have the patients under control. We always make, the reassessments. And my challenge for me is not to send the patients too early, because still we have so many issues. But again, not too late, as you said. It is really difficult. And, I have the luck that I work at the university and the transplant team is just next door. So, we discuss always. But it is really, really, really a very, very, to me, one of the hardest decisions I have to make together with a patient. It's very hard, also for me.
I think you said something very important, which I wanted to address. You said together with a patient. There's one phrase here: patient preference should be a key driver when considering a BMT. For a patient, it is very difficult to say that. I think, he needs a very good support. He has a very good relation with a physician in order that, he can advise him what would be the best, because we don't know. We have not studied medicine. I mean, you have to take that decision mostly in times when you feel bad. So are you taking the decision because you just feel so bad, so it's my last resort, etc., etc.? I think this is a very, very delicate question, who at the end has to take the decision about doing it.
It is a very easy situation with AML. We have clear criteria. Yeah? The disease, if you don't get transplant, you will die. So even for a patient, it is much easier. But here, there is no right and wrong. And, each treatment we give, I always say the difference between transplant and other treatments we can adjust, we can change, but transplant is an absolute one way. And so, we need sometimes several months together to speak with the transplant team, with me, with the family, and we do speak again and again, but my experience is that at one day, every patient knows exactly what to do. And for the younger ones, the fitter ones, they always go but it takes time. And thanks God, in most cases, we do have time. With you, it was quite critical.
So sometimes I remember being faced with a patient that was referred to transplant to us, and then the patient was put on a JAK2 inhibitor, and he got so much better that he thinks, well, do I need a transplant or not? Because when they referred to us, they were in either intermediate to or high risk according to the DIPS score, and then they jump to intermediate one or even to low risk. I think this is where a molecular diagnosis can be very helpful. I don't know whether we agree with it or not. No?
I cannot agree with you, because we have the data from the problem with transplant, rare disease, and from this rare disease we only are transplanting 5, maximum 10%. So you cannot have randomized phase 3 trials. That is our problem. But you transplant people have shown us that transplanting an ASXL1 mutation, for example, doesn't really make a difference. It is still a bad thing, even transplant. So the question is always, what does transplant correct? As I said, high risk, fully agree. The point is exactly, ROX, the patient feels well and he says, bye-bye, I will not go to transplant. But again, we know that when we transplant people, if they are responders, we will have much better responses than if I send you the refractory patients.
Yes.
So that is the dilemma we face together, I think all of us, and we don't have a right and wrong, and it is always an individual and a very hard and time-consuming decision we have to make. And we have not to wait too long until we get AML. You were really lucky,
Wow. Yes,
very lucky,
yes, yes.
yeah.
Yeah, because the numbers we've seen about surviving, they dive deep until 25% if your MF morphs to AML. So that's why I stated keep track of your blasts and be aware that they don't come too high. Then you're too late.
Yeah.
Yes, that's true. It's a very tricky disease to transplant, very tricky.
I know you transplant people don't like MF. No. Every time I send MF, yeah, because it is a challenge.
It's a challenge, yes. I mean, people, the transplant is very delayed. I mean, fibrotic marrow doesn't engraft well, so patients are neutropenic and thrombocytopenic for a long period of time. They stay in the transplant unit much longer than all the other patients. They tend to get more complications. So honestly, I must say that it's not my favorite patient to transplant. But forgive me. but having said that, I think we need to change our mindset and think, well, we have all these new molecules that are improving results, and maybe it reminds me of the time when we start transplanting patients with acute leukemia. Patients were not transplanted in first remission, or even better, I mean, the best example is chronic myeloid leukemia, which is not transplanted anymore, but at the beginning, patients were referred to transplant only when they were in accelerated phase, and results were really very disappointing. When patients started to be referred in chronic phase, in first chronic phase, the results improved dramatically. And it was one of my favorite diseases to transplant, apart from aplastic anemia, where we get the best results, really. But CML patients in good condition, those patients were really the best ones to transplant. Maybe here we came to this point in myelofibrosis. I mean, we know that the natural history of the disease, if patients, when at some point were in the high-risk category, the response to a JAK2 inhibitor is not going to last forever. Patients we are going back again into a high-risk group. So why not consider transplanting them when they are in the best condition possible? Because then we get something like 70%, 90% overall survival at 5 years. It's a risky treatment, of course, it's risky. That's why we need to involve the patient the patient and the family in this decision. And it's very important to have a very strong support, family support, as you mentioned, and a caregiver that can be at the side of the patient most of the time.
Absolutely. Most of the, I say always for me, it is the most difficult decision we make together. But I think, you know, a few years ago, the transplants said only transplant, everything else is useless. We hematologists, the non-transplant hematologists, transplant is terrible. But, you know, I think we are working closer together. We counsel our patients together. So I think also this, from this side, it is quite improving in the last few years.
I agree with you 100%. 100%. I think it's a joint effort.
Yeah, it must be, yeah.
I also want to say something that is also really important, and from the patient point of view, it's really important to understand the process of transplant, because many of the patients have never received intensive chemotherapy before, are adjusted more to having oral medication. So I really agree with you to explain the platform of transplant. We're going to be in charge inside of the hospital during 10 days, most of the time receiving intensive chemotherapy. Well, those for the point of view of patient is really important to understand before to go to the procedure. And also, what you say, the most important thing is the caregiver, because the post-transplanted period is also really important. To control the medication, to control the side effects, you need someone to be on you, with you, during the next 6 months at least.
I just want to add one point. For most of our patients nowadays, we don't use very intensive conditioning regimens. We use what we call non-myeloablative treatment, and that is much better supported. It doesn't have the same toxicity as very intensive chemotherapy. It's much milder, and because we are really playing with the immune effect of the transplant, we are allowing for the patient to have his own cells and the donor cells at the same time, and then we by playing around with immunosuppression. Keep changing microphones, it doesn't matter. By these RIC regimens, we call it reduced intensity regimens on non-myeloablative, have really contributed a tremendous lot for the good results of transplantation in myelofibrosis. There's a learning curve on how the best way to use these regimens, because you have to play around with immunosuppression. You can't really go reducing the immunosuppression very quickly because the graft can go away, or you can get graft-versus disease. So we have to find an equilibrium in between the two conditions. But by doing that in the appropriate moments, we can get very good results without the heavy toxicity of very intensive chemotherapy. Sorry.
Thank you. Yeah, from a patient perspective, I would say that I was well informed when admitting to the hospital, got a paper with every day what's going to happen, what medication, what it's for, what are the side effects. And I thought, well, they know what they're doing. I'm not the first patient. They know what they're doing. If I step on a plane, I also don't ask on the pilot, can you fly? And he flew always on the plane, and I also do. I'm not naive. I'm very well informed, but the nurses and the doctor in the hospital, they guide you through the whole process. And also afterwards, they help you with diet, habits, like behave like it was COVID, be careful, meeting people. They know what they're doing, and they help you very, very much. It's like a machine, because you're not the only patient. And of course, I want to thank my wife, because without her, I wouldn't be sitting here. That's really true. She was the support you need from home is very important, because first time you cannot do a lot. And yes, that's what I was forgotten to say.
Now, we didn't have any questions from the public, from the other patients sitting here. Does anybody want to use the opportunity to have?
Hello. Yeah, I wanted to ask you. I wanted to ask you, Alejandra, the stem cell donation. I think there is a lot of knowledge, and there is a lot of unfounded fear towards it. I suffer from PV, and when I was diagnosed, I had a speech with my children, and they were really afraid of it, because a lot of people think that the donation is not from the peripheral blood, and there are a lot of misunderstandings. There is no misinformation from your point, but the information is not reached to the important people that it should, because from 40 on you cannot be a donor anymore. And I wanted to ask you, how are you seeing now this aspect? Should I answer in English or in Spanish?
From REDMO, somos conscientes de este problema, and we are really conscious about this problem, and we are trying to develop more information for young people and explain the donation process. And we are planning campaigns for young people in order to understand this process. Y sí, hay un gran desconocimiento en la población general acerca del proceso de donación, y estamos desde REDMO intentando mejorarla para difundirla a través de redes sociales para que entiendan que la donación no es la zona espinal, sino es a través de la stem cells process. So we are trying to improve that. And also we need young donors. We need donors younger than 40 years. So we have like a major subject with our universities, schools, to try to understand this process. And yes, we are conscious about that, and we will try it. We will try it to improve, to collect youngs for transplantation. I don't know if anyone have another question. No. So when we select a donor for a patient with myelofibrosis, as doctor said before, we always select a patient that wants to do peripheral blood because have most steams, and also a donor that wants to willing for a second time, that is willing for a subsequent donation in case lymphos or the donor lymphos infusion is needed, or a second blood product request might also need because the fibrosis of the medulla. Yes, wanted to mention that in order to close the subject. Yes.
I have one small question. Can you donate twice?
Yes, you can donate twice. You can donate twice with peripheral blood. You can donate twice bone marrows. You can donate bone marrow and peripheral blood, but all the second donation is not as fructiferous as the first one. It doesn't, from the donor's point of view, nothing happened to you because stem cells, as I explained you, they have the capability of remodeling and growing again. So it's not stipulated how many times you can donate, but legally to preserve the donor safety, twice. Okay.
We saw some numbers of the relapse after a stem cell transplant. I know several people that got from myelofibrosis a second or even a third time a stem cell transplant. So the first one failed, and they did another one successfully. So that's the relapse from one time, but you still have a chance for another one.
Sorry, I just had a question. So if you have ET per se, you wouldn't be able to donate, right?
See, if you have a myeloproliferative disorder, you are not be able to donate.
Oh, okay. Thank you.
Yeah.
Actually, for both of you, and you being a patient with this donor list, I'm wondering how long did you have to wait? And especially, I suppose, O positive is a universal donor, but they can only receive, I think, from O negative. So I know this whole donor process is complicating, but I was just wondering how long on average do normally a patient, or how long did you have to wait?
From the data of our register, since the moment a search is started, so if since the moment we have a request for doing a research, that this is also important, that the medical doctors start the search as soon as possible when they consider a transplantation. We have a median of finding a donor of 2 months. So in 2 months, we'll have an answer. it could be the best answer. It could be a 9 to 10 donor HLA compatible. It could be lucky and have a 10 to 10 HLA donor. So, or you can also have 3 possibilities, as you say before, or you can have non-possibility, but we will have an answer in 2 months, in a median time of 2 months. 50% of the patients find a donor in 27 days. But it needs the search to be started. So this is something important to coordinate with your doctor, that they start the search.
I was diagnosed in the end of October, and as I told you, I will immediately ask for a stem cell transplant due to my bad symptoms. End of October, and we first checked my brother. He wasn't a match, it's a 25% chance. And then we searched the worldwide donor bank, and they found 3 donors, and it was my initial transplant was on February 12th. So from the end of October until February 12th. So it's I think it's a short time. But I agree that if there's a chance that you might be needing an MF patient at high risk, always do a search for a donor. Then you can you can be in time. You do not lose time, precious time that you need if the numbers get worse.
Everybody together.
No.
Yeah, no. We don't want to have a transplant. That's basically the first thing. And it's 95% of us we will not do it.
And also another important thing to know, and is part of your question, we keep the search for 1 year. After 1 year, if it's not a result, it's impossible to get a donor. But we keep looking for 1 year after the search is starting. So if you don't get a response in the first months or in the first 2 months, the searching keep going 1 year and ahead. Okay.
And you have to count with the possibility that you don't find a donor. This exists. A very good friend of mine here in Spain, he is looking for a long time already, and he can't find a donor. So it's very difficult, yeah.
Yes, it depends on your HLA. If some person have a HLE really difficult to find, so that's why we need more donors to be to big possibilities.
Well, worldwide, how many donors do?
43 million.
43 million. It's a huge quantity. And that you would think, in 43 million, I have one here, I think so, yeah. In 43 million you should find one, but there are cases where you cannot find it, unfortunately. But keep on searching, and thanks to people like they are, that whole thing is working. And what I would like to do is, I know you are very good in these things. Peter Rocher, who is a friend of mine, went through the whole thing. I really would like to put more attention to the donor. We need more people. I mean, apparently 43 million is not enough. So, we have to work on that, and we will talk about it, yeah, one of the things, yeah.